Yes.
It's not going home.
Should have everybody up there. Yeah.
I don't know. Yeah, I said the same.
That's why I'm wondering, like, in this room and.
Yes.
It's much better. Well, so good morning, everybody. Thank you for making the session this morning. I know it's Saturday, and we had the big banquet last night, so hopefully folks will filter in. My name is Flavio Roca. I'm from Oregon Health and Science University, and I'm delighted introduce our speakers today for the annual Cholangiocarcinoma Foundation HPBA Combined Symposium. And we have a little bit of a very multidisciplinary lineup, which is the hope of the session. We have some talks, and then we're also going to have a case discussion. So first up, we're going to have Dr. Amanda Notke, who's a PhD scientist at Citizen and Vitae. Dr. Shishir Mithal, my colleague from Emory University, talking about a novel approach to a global prospectively maintained cholangiocarcinoma database. And I believe this first one is a virtual, so we can just play it. Thank you.
This is a pre-recorded presentation. I wish I could be there in person with you all. However, I am logging in live via Zoom for the Q&A portion, so look forward to the questions and discussion at that point. So today I will be providing an overview of the database itself, describing the current cholangiocarcinoma cohort, then walking through 3 case studies that illustrate the types of research possible with this data. So taking a step back, ultimately, Citizen, now in Vitae's objective in this registry is to collect high quality real world data from medical records in a way that is not limited by institutional agreements or by the structure of the documentation, for example, within a particular electronic medical record system. And by doing this in a patient-centric manner, it also simultaneously is ensuring that participants benefit from having full access to and control over their clinical data. And furthermore, it supports an ongoing relationship with the registry participant that enables prospective follow-up. So how does it work? When patients or participants enroll, they tell us where they have received cancer care, and they consent for us to use the HIPAA right of access on their behalf to obtain their medical records. So in the United States, HIPAA, or the Health Insurance Portability and Accountability Act, ensures legal right of full access to individuals to all of those medical records. So once we collect the records are hosted on our platform where the participant controls access. They can log in themselves, they can share it with whomever they wish for a second opinion or any other use. Next, we process the records through our pipeline, which begins with optical character recognition to read all of the unstructured data, and then the machine learning driven piece of the pipeline searches through all of this text to surface likely candidate clinical data points. Each data point is then confirmed via 2 rounds of human review. The data is ultimately de-identified, standardized and structured, and upon patient consent is available for research use. So what do we mean by standardized and structured? We can think of it as layers of organization for this data. So foundationally, there's the terminology. So our process translates raw medical record text, which is not just exact matches, but can be abbreviations or shorthand. So for example, it might mention ERPZ in the medical documentation. This is recognized as aligning to the standardized term endoscopic retrograde cholangiopancreatography that has an associated SNOMED code. The codes are important because they allow for normalization and standardization over time, data portability. They also support hierarchical relationships between terms. So for example, individual medications, regimens, medication classes. So the terms are then organized into the appropriate category of clinical data. So for example, a raw text mention of Gemzar, a brand name, is first assigned to the standardized term of gemcitabine and then categorized as a medication within the ontology. The terms are also associated with various attributes, including the date that they occurred or were observed, or a date range in the example of something like a medication that goes on for a period of time. Finally, we have the disease model. So each data point may be connected or modeled to other data points to show a relationship. Typically, this is a causative relationship, so an adverse event being associated with the therapeutic intervention that it was stated to be caused by in the text. It can also represent a site of disease. So For example, one of the clinical characteristics like a grade or histologic subtype can be modeled to either the primary tumor or a specific site of metastasis. And so taken together, the structure means that the data is standardized across the cohort and also supports very detailed subgrouping and querying and analysis within the data set. So next, I want to show you what this looks like using an example of a real individual data set that we have within the cohort. So once the data is extracted and organized, we can see a comprehensive longitudinal picture of the patient's cancer journey, including clinical characteristics. So you can see at the time of diagnosis and diagnostic workup, first we have high-level demographics, but we also have the details of the diagnosis. So intrahepatic cholangiocarcinoma with a metastasis to lymph nodes, described with lymphovascular invasion and said to be surgically unresectable. Also have stage information and grade, histologic type, and biomarkers at the same date of this biopsy. We also have a germline biomarker panel that's done. So in addition to the various clinical characteristics, which are not just at the diagnostic workup necessarily, but will be collected at any point that they occur in the documentation. In this instance, we have the initiation of gemcitabine and cisplatin on this date. And so one thing to mention here is that our data distinguishes between a known start date, so documented as starting on this date, between a known start and end date versus just the earliest or latest mention of something in the data. So particularly with medications, in the documentation, it might show up as patient presented to clinic today, currently on gemcitabine. So we know that that day they're on gemcitabine, but it's not their start date and it's not their end date. So in this data set for these two drugs, as well as the durvalumab that starts at this later date, we don't have the end date, but we have the latest date. And so this distinction is important as you consider how to calculate various endpoints or outcomes that are related to dates. So we capture those details of the medications. You can also see a lot of detail with adverse events, including the dates, including the modeling of what it was associated with. You'll also note that we have a specific capture of impact of adverse events, namely a dose reduction, as well as a treatment hold for adverse event resolution. So this allows us to look at the impact of adverse events on compliance and duration of therapy. And finally, there's the outcomes. So an important thing to note in general is that we do not make inferences. So everything is based on what the clinician is stating in the documentation. And this is true for disease or tumor status as well. So here, the clinician declared a partial response, noted a stable, 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 and then another partial response at this point. Okay, and so you can imagine that as we build multiple longitudinal case views like this, we are well positioned to explore some very interesting questions. And I like to refer to this slide as the menu. These are the things that we can look into within the data set, bucketed by clinical characteristics, including high-level demographics, interventions, and outcomes. And so the types of questions that this data is well suited for include things like characterizing a diagnostic journey, looking at biomarker testing, which we'll get into with the example case studies, looking at real-world utilization of various interventions, what we might call a treatment landscape, and then looking at endpoints, efficacy endpoints. So being able to calculate things like time to clinician-stated progression, overall survival, duration of response. And then there's also looking into tolerability for various interventions. So looking at what adverse events are occurring and what their impact is. Now I want to introduce to you the current cholangiocarcinoma cohort. So as of February 2023, we have data for 372 individuals. The sex is reported here, as is the year of birth, mean and median. Year of diagnosis is either mostly 2019 or 2020, depending whether you're looking at the mean or the median, but you see this nice long tail of long-term survivors. So we have diagnoses going back to 2007. However, most of them are clustering over the past few years, which is when the registry began enrolling. In terms of clinical characteristics, we have assessment of percentage with distant metastasis at the time of diagnosis, as defined here. We also have the diagnosis details. So you'll notice that 23% approximately of this cohort have cholangiocarcinoma as a diagnosis, not specified intra or extrahepatic. That's because nowhere in the documentation did the clinician make that declaration. So we record the most specific diagnosis. So here you see percentage with intrahepatic, and then a similar story for extrahepatic. If it's not specified, we've got the 6.7%. If it is specified, it's documented here. And then finally, it's likely of interest to know the targetable biomarkers that are observed in this cohort. So here we have IDH1, FGFR2, the MSI high, DMMR, TMB high, HER2 positive, as well as RAS B600E positive. So now I'd like to get into the case studies. So the first one that I want to share with you is an example of a very common question or interest in real world data, which is to look at real world utilization of a specific medication or regimen of interest, either just individually or in the context or compared to a comparator regimen. So here at an earlier point in the registry, we took a look at 150 individual data sets to explore what was then an open question about the gemcitabine cisplatin, GC, and gemcitabine cisplatin Abraxane, or GAP regimens in first-line cholangiocarcinoma. So we looked at how long is each therapy used, which speaks to both efficacy and tolerability, as well as what outcomes are associated with each and on what time frame. So measuring the time to first clinician stated progression. So in panel 1, you can see that both the duration of therapy on the left here, as well as the time to first clinician stated progression, you can see the distribution of these measures in days, and also see that there is not a statistically significant difference between them in this data set. And similarly, in panel B, the first responses to therapy, which are green for response, yellow for stable, red for progression, are also not statistically significantly different. Now in panel C, this is showing each individual data set. So the horizontal bars are for each individual, and they show the number of days from the start of therapy till the end of therapy. So that's in blue, the duration of therapy when known. And then the orange is the extension on to the time of first clinician stated progression. Then each row is labeled on the left with the first documented clinical response, whether it's response, stable, or progression. And so this demonstrates the ability of this data to explore in good detail some of these endpoints that are relevant to understanding the utilization and outcomes of specific medications or regimens. And so next, I want to show another example, also calculated at this point in time, starting from 150 individuals, providing a treatment landscape view for a therapeutic class of interest. So in this example, the checkpoint inhibitor immunotherapies. So in this table, you can see individual immunotherapy regimens are grouped by regimen type, for example, chemo-immuno combo, with the details of which medications were included, the line of therapy, LOT, the duration of therapy in days, as well as the best response and time to progression, or TTP, also in days. So in addition, as I mentioned before, we collect the impact of adverse events, specifically holds, dose reductions as reported here. So in other solid cancers, there are specific biomarkers that are associated with better likelihood of immunotherapy response, namely high tumor mutational burden, or TMB, microsatellite instability, or MSI high, PD-L1 expression positivity, and mismatch repair deficiency, or DMMR, as opposed to proficiency, PMMR. And so here, when these biomarkers are detected, it's highlighted in yellow. So you may, notice as you look across these rows that while the response to the chemo-immuno combos does not seem to have any pattern of association with any of these biomarkers, the monotherapy data, circled in red, does show an interesting pattern of positivity in one or more biomarkers with response or complete response, even in later lines of therapy. So we look forward to continuing to expand on this analysis and also explore this for other classes of therapy as well as candidate biomarkers. And now for the third example, last but not least, I'm excited to share an ongoing project that is not only identifying insights about biomarker testing and incorporation into clinical practice, but bringing these insights back to individual registry participants. So the context here is given the increasing relevance of biomarkers with the approval of multiple classes of targeted therapies in recent years, we expect that biomarker testing should be done at or near the time of diagnosis. So we took a look at it in the entire data set, the 372 that we have now. So looking at the days between diagnosis and time to first biomarker testing on the y-axis, and then looking based on date of diagnosis going all the way back to 2008, you can see this very nice trend of decreasing time to first biomarker test and this really nice clustering right at the time of diagnosis, where all these individuals are being tested at their time of diagnosis. And in fact, if you've been by individuals who are being tested within 30 days of diagnosis, you see this very nice jump right around the time that targeted therapies are, becoming available, and then a very high prevalence of biomarker testing at time of diagnosis within the 2022 cohort specifically. So this is great to see, but of course the next question is, what did the testing find and how did it apply to treatment decision-making, specifically the use of matched targeted therapies? So here we're looking at 5 classes of targetable mutations. So first, IDH1 R132, second, FGFR2 rearrangements or translocations, third, MSI high and/or DMMR and/or TMB high. This is related to the pan-tumor approvals of certain checkpoint inhibitors, and then HER2 positivity, and finally BRAF V600E mutation. So the greenish bar shows the number of targetable mutations where we see a matched targeted therapy in the data. The reddish bar shows the number of targetable mutations where we do not see a matched targeted therapy in the data set. You'll notice right away that many, in fact, over half of the mutations do not have evidence of a targeted therapy in the data set at the time of data collection. So our next step is to look into this, to examine the other clinical variables we have in the data, to look at how early are they in treatment. These targeted therapies are not approved until second line or later, right? We want to know when the treatment decision was made relative to the approval date of the matched therapy. And of course, other aspects that could influence eligibility. For example, biomarkers can change over time. So a more recent biomarker finding may not, in fact, support this matching. So sure enough, we see that the majority of the mutations without a matched therapy are early in treatment. So the ones labeled here as 1L or first line data only. So this majority are so early in treatment that they would not currently be eligible for a matched targeted therapy. Other reasons we see in the data are that a different targeted therapy was selected. So some of these individuals have more than one targetable mutation in their cancer. The targeted therapy was not approved at the time the decision was made. Some are not eligible upon further review. So again, this might be a biomarker has changed, or perhaps they're in remission currently. But there is, however, a subset where, based at least on the biomarker and the line of therapy and the timing of that treatment decision, they did appear eligible for a targeted therapy. So this leads us to one future direction for this analysis, which is to explore the demographics and other clinical characteristics to try to understand why that happened. But the second part is also really exciting, which is that looking across this data, we see that there are 62 individuals that where we do not see data for a matched targeted therapy in their data set, so at the time of data collection. And they may now be eligible, or they may in the future be eligible for a matched targeted therapy. And I'm very excited to report that we are planning outreach to these individuals to provide this personalized insight from their data and encourage them to discuss with their physician, and also to survey them to understand potential barriers to awareness or access for these targeted treatments. And with that, I'll close with some future directions and acknowledgements. So just looking ahead, we are excited to continue growing our US-based cohort. Currently have over 500 individuals enrolled with more than 500. So 800 individuals enrolled with more than 500 with records collected. And we'll be incorporating survivorship data, not just at one point in time, but we'll be having prospective refreshes of that data to enable overall survival calculations. And we're also interested to, continue exploring international expansion of this registry. And of course, continuing our collaborations, which leads me into my acknowledgments. So first and foremost, need to thank the Cholangiocarcinoma Foundation and their network of clinician researchers who have helped us design and launch and enroll this registry. Also need to thank the Invitae citizen team for their tireless efforts towards generating this high quality data. And most importantly, the individuals who have joined the registry so that their data can contribute towards greater understanding of the disease and acceleration towards better outcomes for cholangiocarcinoma patients. So thank you all very much.
Thank you all for coming. I'm just going to add like 1 minute on top of this and really try to emphasize the high points. I would encourage you all to ask your patients to enroll in this database. This is a very unique thing, and Amanda did a great job explaining this, but I just want to highlight a few things. One, the data collection doesn't require any work from any of the physicians, providers, database coordinators, or anyone at the institution. So this is a completely outsourced database collection method. Two, because of the nature of this, I've actually left some cards on the front desk here, or you can visit the cholangiocarcinoma booth in front of the exhibit hall. But really, it just matters. Your patients just need to sign up. It's free registration for patients. It takes about 30 seconds to sign up, literally like 2 questions, and you're linked in. It automatically allows the Invitae team to access the database and the records, the medical records for the patients at every institution that they've been treated at. So often, like Henry, if you have a patient that comes from 3 different institutions and they don't have their records collected, this system actually collects all the records together and puts it together in a single file. So it's free for patients. It takes a second for them to do. There's no IRB involvement at your own institution because this is a third-party database. This is the ability to go national, which we're already going national. And as Amanda said, we're trying to go international as well, starting with Canada, but eventually planning to go to Asia as well. And the amount of data we're getting here is phenomenal in terms of the molecular biomarkers, the treatment, and then the other thing is a lot of data sets that we collect in our own institutions are cross-sectional databases. We have planned 6-month reiteration, so this will be a living, breathing, prospectively maintained, following for recurrence and survival. So as this grows, there's a 700, I think, already in here. We have a full 350 or so annotated, but as this grows over the years, this is going to be an incredible resource to study, and actually will remove all of the work from physicians, providers, and patients and puts it into this mechanism, which I think will be precedent setting, very novel, and will actually move on to other histologies, whether it's cholangio, pancreas, gastric, anything. I think this is going to be an incredible thing. And ultimately, we're going to start, analyzing the data as we would, but not only for papers, but also the goal is to use this platform for pragmatic clinical trials. And so this will hopefully be similar to the NSQIP thing, but this will be, again, beyond 30 days and a little bit more oncologically focused, but ideally doing pragmatic clinical trials. So please encourage your patients, please pick up some of these cards, take a stack. I think we bought a lot of them. So take a stack back home, hand it out to your colleagues, literally just have to hand it out to your patients. They can click on it and the rest goes automated from there. Thanks. Great. So just move right along. It's my distinct pleasure to introduce Dr. Marina Beretti, who's an assistant professor of oncology at Johns Hopkins University School of Medicine. She's originally from Italy and actually trained at the University of Milan, where I have a connection as I live there myself. And it's a real pleasure for her to come here and talk to us about the molecular management of biliary tract management today and the future. Dr. Beretti.
Okay, thank you so much. It's really a pleasure, and thank you for inviting me to join this esteemed group today. And it's really exciting to discuss, precision medicine, biliary tract cancer today, because as you can see, Over the last few years, we have made really unprecedented progress with the approval of different combination of drugs and different molecular target therapy just in really few years, with a rapid transition from a bench to bedside. And under investigation, we have more drugs to come. And so this has been possible because we have a better understanding of what is the molecular makeup of biliary tract cancer. We know that these are a heterogeneous group of malignancies whose heterogeneity does not rely only on the anatomical side, that is intrahepatic, extrahepatic, gallbladder, but truly reflect a different etiology, different biology. And so today we really divide these groups of malignancies more and more based on the unique genomic alteration, the higher proportion of potentially targetable alteration as of today seen in the intrahepatic subtype. So you can see that really precision medicine applies to biliary tract cancer. And I'm going to try with my presentation to highlight what is the standard of care today and what are the potential future direction. Starting with the IDH1 story, IDH1 mutation are seen in approximately 15% of intrahepatic cholangiocarcinoma. So it's enriched the intrahepatic subtype. Tumor types such as glioma seems to have a prognostic role. I think it's unclear what is the prognostic role still. Cholangiocarcinoma. This mutation leads to the accumulation of the 2-hydroxyglutarate, which as an oncometabolite affects cellular differentiation. IDH1 mutated cholangiocarcinoma based on the Clarity study. This was a randomized phase 3 study, double-blinded and placebo-controlled. Patient with advanced stage IDH mutated cholangiocarcinoma were randomized to receive ivosidenib versus placebo. And because the control arm was placebo, it was felt kind of necessary to allow crossover. And you can see that up to 70% of patients actually did cross over to ivosidenib at the time of progression. The study was positive from a median progression-free survival standpoint. But you can see that the curves diverge and they stay separate, which also raises the question: is really drug or maybe disease biology? Disease of survival was a little clouded in the intention to treat population because of the crossover. Adjusted for crossover, there was also significant survival. Patients that can have a durable benefit with this medication. So we need to be focused on trying to understand who these patients are. Unfortunately, the moment that we talk about targeted therapy, we kind of necessarily also potential emergence of resistance. Resistance to IDH1 inhibition are treated with ivosidenib. At the time of progression, response to develop in IDH1 itself. So from this type of reports, you can see how with a large biopsy ctDNA this mechanism of resistance to think about better sequencing and perhaps also this is what is happening in the IDH1 and I do want to write in this is novel and highly selective towards this most common secondary resistant mutation. So we are very lucky to see the results of this drug, which is investigation either as a single agent or in combination with chemotherapy. Focus on the Ahpba story. This is a very beautiful and successful story for cholangiocarcinoma. These fusions of the arrangement are seen in approximately percent again reached in the intrahepatic cholangiocarcinoma. We're starting to generous and actually President Morgan last these fusions. And as you might know, we have now different drugs that bring the treatment of this subtype of cholangiocarcinoma. The drug was approved, was completed based on this 202 trial, was a phase 2 open label single arm trial in which cholangiocarcinoma FGFR2 phenotype with the FGFR2 fusion arrangement positive. And as you can see, this was absolutely a very positive study. 7% to support this is a true survival as well. Surpassing historical data is refractory population. So as I mentioned, based on this first 2 study, there was an accelerated approval. Which also means that we do need versus chemotherapy. The question in this case an irreversible inhibitor based on the CCA2 study, positive study, positive response rate. Surpassing any historical data. Also had infigratinib that was approved with FGFR2 fusion, but with the decision to discontinue the presentation. As you can see, the next as only new therapies coming for FGFR2 positive cholangiocarcinoma. So raise the question about what is the better way to use this trial to sequence this drug. So that we have it in cross-trial comparison. So really, the message is that these drugs in this molecularly selected population. But it's also true that there are some challenges. First, there are some patients who, despite having the fusion, do not respond in the first place, and then almost inevitably all patients eventually progress. And so I really think that this underscore our importance to identify better predictive biomarker of response and resistance. This is particularly relevant in FGFR2 carcinoma because we are actually diverse molecular subtype. 64 so why this is important is because the initial data supporting the hypothesis that this computational spectrum to impact the efficacy and the outcome of FGFR2. To have the communication to suppress regions and loss of blood. So shows, of course, we're talking in this analysis of limited numbers. So these drugs and clinical setting provide gradually that able extremely important to understand which extent the efficacy of these drugs. So this can guide the sequencing of treatment or combinatorial approach as well. And as I mentioned before, the therapy about resistance. Cases of secondary resistance for FGFR have been a little better described. So we know that upon the continued pressure of FGFR inhibition, the origin of secondary function, the more which is able to convert This is second of my question. What I want you to take away from this as well is about resistance is about to my ethnology these drugs. And this other as well. So as mentioned, it's this this is a challenge as a the generation of active inhibitor. This time, the one I mentioned, is selective object to inhibitor, which is a very strong product that works. Generation was difficult to go active as to object. Which is a trial, and this is the percent of the all this is we have an investing responsibility. It's up to 90%. It's also including the structure of the business of the object to the sector profile generation which is the active is not really so this is drug that is going to be the trial looking at the interest subset because we have other drugs under investigation. Particular acid is it's antibiotic, is another specific antibiotic. This published in we're so interested in that. To study is to treat it carcinoma. Simply, you had also the this is a molecule of person. So that's not so all of them this is a drug that is toxicity. So striking that is extremely important to identify this patient that can benefit from this with specifically I think the genomic profile patient would subtypes that can have but also to enable our better understanding basis of resistance or response to a given treatment. So do want to acknowledge some challenges in the application of medicine in cancer. The it's feasible, especially for the extrahepatic cholangiocarcinoma. Tissue is just not sufficient to do the sequencing. As you know, it's not always easy to read a biopsy, but it does pose a not negligible risk for our patients. So the other point is that we do get a biopsy at one site, so we need estimate the true extent of the majority of this. To follow longitudinally the genomic profile, which can be extremely important in the context of disease control. This basket trial. Some complexity of research. The bacterias will discover that the bacterias we use them. So in that now the is intended advance in the system, understand the subset.
Thank you, Dr. Brody. I mean, that was an amazing review, especially for, a mostly surgical audience, but we're really delighted to partner, I think, as you said, with the pillars of treatment and then with the molecular therapy. It's my distinct pleasure to introduce Melinda Bikini from the Cholangiocarcinoma Foundation. Melinda is a 13-year survivor of cholangiocarcinoma. In 2012, she was actually one of the first patients treated at the NCI by Dr. Rosenberg using adoptive cell therapy with TILs. She actually is an EMT paramedic, has been an EMT paramedic for 15 years. I had the pleasure of being on at the Cholangiocarcinoma Foundation, where she serves as a director of patient services. She also serves on the ECOG Akron GI committee, the NCI Hepatobiliary Task Force, and the NCCN Hepatobiliary Guideline Panel. She's also a mother of 6 children. I'm a grandmother of 2, which I still can't believe. And it's her wedding anniversary today. And she'll be talking about the patient perspective. Melinda.
Hi, everyone. Thank you for having me. Again, I'm Melinda Bikini, Director of Patient Services with the Cholangiocarcinoma Foundation. I'm a 13-year survivor of stage 4 intrahepatic cholangiocarcinoma. I've experienced surgery, recurrence, chemotherapy, the decision to stop all treatments for a better quality of life, and then finally a clinical trial. 3 months after my liver resection, I had a recurrence of disease and was given only 6 months to a year to live. After stopping all treatments, I stumbled upon a clinical trial with Dr. Stephen Rosenberg at the National Cancer Institute. I was the ninth person to enter the trial and the first person to have a response. This treatment reveals an on-hold 13 months later. At this point, it's been 11 years since I first entered into that trial, and it's also been 6 years since I had a treatment with carcinoma. So after I'm dead, we're all good. I want these results for all carcinoma patients. Such a great response. I had to find a way to put it forward for the carcinoma patients. Most of the carcinoma clinical choice is a matter of my diagnosis to volunteer at the foundation 11 years ago. 6 years ago, I was fortunate enough to be able to be honest with you. To all areas of research, try to represent all forms of carcinoma patients. My foundation had raised myself. Through a newly diagnosed program, to source educational webinars. We collaborate with academic institutions around the U.S. to host regional symposiums, exhibition targeted both at campus and Salt Lake City. We receive a group of about 30 research advocates who regularly give feedback on teaching materials, clinical trial design, and participate in person advisory boards. CCF has a one-on-one mentorship program for patients and caregivers called Clover. 2021, CCF started a newly diagnosed program to reach newly diagnosed carcinoma patients if possible. With a plug, the matters will hope to provide people to original situation. Around 7 this past November, we revamped our email series that patients receive after the summit for this conducted and updated on the diagnosed survey. I'd like to present some results of the 65% of patients signing themselves up for the program, and 25% of their caregivers who send them in. 4% of patients had intrahepatic carcinoma, 14% very heavy, 10% had distal. Interestingly, 26% of the patients are unsure of what type of specific cholangiocarcinoma diagnosis they actually have. The majority of patients finding the cholangiocarcinoma foundation are non-Hispanic. This means we are now working on ways to try and reach all diverse populations. We translate materials into different languages, student and Spanish support group. 7% of finding CCF through Google Facebook searches are being referred to the physicians. So please share this into patients our way so we can help support them. Just provide the treatment options by their doctor or medical team. 65% of the patients agreed. 60% agreed that they understood the treatment options that their doctor and medical team provided them. Whilst if the patient was encouraged to receive a second opinion, 47% agreed. 100% of the patients were provided information about biomarker testing. 60% of the patients had biomarker testing completed. 34 of the 62 patients that didn't have biomarker testing completed, the reason for having it done was that the doctor did not recommend it. Diagnosis to receive biomarker testing. The patients were provided with information about clinical trials by the patient's doctor and medical team, and about 21% agreed, which is disappointing to hear. No better access to clinical trials and to be encouraged to enroll in clinical trials by their medical team. 20% stated that after the clinical trial was the first line of treatment option. As a person advocate, to the possibilities of participating in the first clinical trial, including adjuvant clinical trials. About the diagnosis at severe moderate levels. 6 of the 211 patients had no access to emotional support concerning their diagnosis. Some of the patients and caregivers sought information about the diagnosis outside of their medical team. Advocacy organizations and social media to find more information about their diagnosis and to provide and educate them as much as possible. To contact by people advocate the Project Customer Foundation, emphasizing the need to be very involved and educated about their diagnosis. To contact them, we offer help in getting second opinions, providing biomarker testing, and help them to treatment trials. I also want to say that the distributed during CCF annual conference. Attendance to try and gather more information barriers to clinical trial enrollment. Stories presented at several conferences. 60% of the survey were receiving systemic treatment. 57% of them were being treated. 5% were being treated with behavioral therapy. 7% of the patients were treated by an employer, and 35% had Medicare or Medicaid Advantage. Only 1.5% were uninsured. 0% had biomarker testing done, which was mainly ordered by their treating oncologist. 10% of the 204 patients had enrolled in a clinical trial. 79% of those had enrolled in one clinical trial, while 26% had enrolled in at least 2 clinical trials. 23% of the patients were told they were not eligible for a clinical trial with a specific biomarker and were non-measurable disease. Survey suggests that the clinical trial enrollment rate is still low for cholangiocarcinoma patients. Evaluating the eligibility criteria for clinical trials, which is a clinical barrier to enrollment, is crucial. Not just for action-building teachers, we also need to consider expanded access programs and better designed clinical trials to provide treatment opportunities and more hope for patients. Carcinoma patients want to be involved with research through the conversations we have had with the patients and caregivers over the past 17 years. CCF is proud to partner with the Citizen to give our patients the opportunity to do so. Through the International Cholangiocarcinoma Patient Registry, our patients can help power research between the global research community, allowing investigators access to their de-identified methods. To participate in the ICPR, all they have to do is register to join the ICPR, sent to have their medical records gathered for free, and sent to their de-identified data for research purposes. The table, and there's some on the tables here, and so I invite you to step and hand them out to your patients. Participating in that registry. We're not able to help ourselves fast enough, but we want to be able to help those patients in the future. That says their strength in patient numbers, collective data, and other treatment approach. Adds up a registry, we may someday be able to improve early detection, expose any potential geographic hotspots, and understand more reliably what might predispose the individual to biobank cancer. To present today, we invite you to join us next month at Salt Lake City at our annual campus.
All right, well, we have a little bit of time for quick questions for our speakers. Great, and I see Dr. Kane coming up right away.
Melinda, thank you so much for joining, especially on your anniversary. We all appreciate this. You demonstrated a real failure in our healthcare system in general. I mean, patients, the majority were saying that they weren't offered things that we would hope all patients would be offered. It's one of the failures of our non-nationalized healthcare system when you have things like this come up. Have you seen either in this disease or even in other diseases, success either at a state level or an insurance company level or something that the NIH has done that has really successfully overcome this barrier of so many patients lacking access to something that we all would agree is important? Is there some model that can be used, or at least give us hope that this can change for the better?
Oh, wow. I'd like to say yes, but no, I think we have a lot of work to do. I think there's so many barriers for patients to get access, to be able to participate in clinical trials, to have access to second opinions, to biomarker testing, all of that. I think we need to work really hard, especially in the community settings, and make sure that those are offered to the patients. I know for cholangiocarcinoma patients who I speak to every day, they're willing to travel. They're willing to travel at great length to be able to provide a treatment option or an opportunity to extend their life. There's a lot that can be done. I see a lot more companies offering financial assistance for patients who do get to those trials to be able to participate. Yeah, that's not known. And even when the doctor knows about the trial, they don't necessarily know about that financial assistance. So that there's a so model yet.
So you guys have a successful model then.
I would say yes.
No, not just a rare cancer, as they say, right? So I just want to be sure Amanda is perhaps joining us virtually as well. Dr. Cleary.
Hi, Sean Cleary, Mayo Clinic. Melinda, thank you as always. It always inspirational. I really enjoy every time you talk. It's a question really for I guess the panel. And Melinda brought up the idea of clinical trials, especially in first line. And we don't have in this disease right now a lot that's open in first line. And one of the challenges that we have is when when maybe Dr. Roca can comment on this at the cancer center level, when you're based on the funding models, opening up cooperative group trials, it's challenging, and then you're advocating at the cancer center level for a cooperative group trial in rare diseases. How, any thoughts or advice of how we're going to be able to open up that first line space? Because these are the unfortunate logistics of everything. So how can we work with patient advocates? How can we work with our institutions to really get some of those trials? And it's also dependent upon us to write, to get those trials going in first line. Because right now there's a ton of stuff in second and third line. Because obviously everybody wants to look at the new targeted inhibitor, but we do need those studies in first line.
Let's start with that one. Dr. Moretti. There's another red. There's a red button there, yeah.
This one. Okay. I totally agree. It's a big gap in the frontline setting. There are some challenges from a initial clinical perspective. Of course, these patients have some delay in the diagnosis, and then after the clinical trial sometimes does mean delay in further starting the treatment. This is particularly true if we are talking about molecularly targeted therapy in the front line. We have seen the study on tibactinib was some slow accrual, and everything that was done here, then restored out with a couple of cycles of chemotherapy while you were information. I think that's absolutely reasonable. That. That's why so in this population, and so probably we should start to use for the future trial as well. Absolutely, sensitive and hard, because if you don't need the turnover and go information just in a few days, that are simulated accrual as well.
From my administrative hat on, many cancer centers are structured so that each disease site is its own cost and budgetary center. And that really limits sometimes the portfolio of trials you can bring. So I think innovative ways to manage that financial pot, if you will, and try to redistribute those funds to, to sites that perhaps have more trials available at that time and point. So I think that we've see a lot of ways to try to fix this problem. Of course.
It still seems to me that it may be time to revisit the use of artificial intelligence for clinical trial matching. Patients could do on the web with their own information. It's hard. We tried 10 years ago to use IBM Watson and it failed miserably. I would add, but I think the time has come now with ChatGPT and these things. Patients can have more power to put in information and probably narrow down the pool. They'll never get the perfect match, but they can narrow down the pool to do that. Maybe something the foundation may want to think about.
Oh, we are.
I want to say it's really hard. It's a holy grail.
Well, let's we're going to get to the case sessions now because I think this is where I want to really keep it interactive. And it's my distinct pleasure to introduce the rest of our panel that's joined us here today. And so we have Dr. Lisa Tabrizian, who's a biliary and liver transplantation surgeon at the Recanati Miller Transplantation Institute. She's an assistant professor of surgery at the Mount Sinai School of Medicine. We also have Dr. Rajan Lorraine, who's the head of interventional radiology here at the Miami Cancer Institute. And Dr. Lorraine Portelans, who's a radiation oncologist, professor of radiation oncology, as well as vice chair for clinical research here at the University of Miami. So thank you for joining us. First slide. So please feel free to use your audience participation. There'll be some questions in there, so please join through the application. Hopefully everybody can see this okay. The computer is a little small. But we have a 62-year-old female who was only with an incidental large liver mass. Some medical history significant for a partial collective for a colon cancer 20 years ago. Also had a THBSO. She had a family history significant for a sibling and an aunt with colon cancer. See the two markers there, and she was continuing to have her screening colonoscopy, which is good, which was normal. So here's our first audience participation questions. So if we can have the audience vote for the next steps. A lot of folks logged into the app. We're up to the panel. Dr. Mitchell, you're here. So where would you do for this mission?
Yeah, I think I would start with a biopsy, particularly with a history of colon cancer, to basically assess disease histology and make sure we're not dealing with, and obviously a repeat colonoscopy if she hasn't had one. Make sure that this is not colon cancer recurrence. Obviously, given the symposium we're in, we're obviously thinking about intrahepatic cholangiocarcinoma, but I think you have to rule out the other stuff. EGD, mammogram, all the usual stuff.
Sounds looks like on the voting we have here too.
I agree. I think, I mean, since the cholangio session, I was since the cholangio, but I would biopsy and get imaging as well, because it looks malignant just to stage it to see what the next steps are after that.
And send the biopsy for NGS immediately.
Okay, so let's see. Okay, perfect. All right, so here's your NGS. And I know, I apologize for the slide, but it's a liver biopsy which shows a pluripotent adenocarcinoma that's CDX2 negative, CK19 positive. There's a loss of LSH2 and 6. You can see there it was characterized as MSI high with a T1 of 15, and you can see the other mutational variants there. So we have a biopsy. What do we want to do next? Send the audience vote. Systemic chemotherapy. Now votes for systemic therapy, chemotherapy.
I think this is one of those, if you've showed there's a tumor board at any institution, you have different answers. I think there's not a right or wrong answer. I think just looking at this scan, this is resectable, but it certainly has like aggressive features just based on size and the biopsy. I think doing upfront hepatectomy is not the wrong answer. I think a lot of institutions would go with that, but I think there's a push now of treating with neoadjuvant therapy and seeing some test biology testing the biology and give it in test of time as well. So I think my answer of today and my answer few years will be probably very different. But I'm personally leaning towards doing some neoadjuvant therapy with systemic and then aiming for surgery. This is and last I with high tumor mutation burden, which is a rare, finding in cholangiocarcinoma. I think it's probably 2% of all the cholangiocarcinoma in the majority of the report. But so if you the adjuvant setting versus the adjuvant setting, so this is a patient for which I would even spare chemotherapy and consider immunotherapy as neoadjuvant for a couple of cycles, for surgery afterwards.
Perhaps if the tumor is too big. Anybody have a choice for local regional therapy?
So, on this particular case, given the size, I think, now with additional chemotherapy as a first line is very reasonable. In our institution, just James is we were comfortable doing 190. In addition to James, this was first line based on the MISPAC file from France, and for this particular patient to get them, if surgery is an option, and to potentially start with Y90 as the first local regional treatment option. Obviously, to see what the functional liver remnant is on the left side, assuming that that's the only area that's involved. We tend to get MR in our institution in addition to CT, just to make sure that we're not missing anything. And then based on how the Y90 looks in the response, then we decide whether we should do more intervention to improve the liver remnant or stop it. Okay.
So yes, we have a very similar model, but we want to initiate treatment with system. She's also at risk of high range of extrahepatic disease, and then to give the so why we're successful.
We have spoken about this before. So, how do you tell a patient with a resectable liver lesion to say, no, you should get systemic therapy first?
Yeah, so I know that's what I just said. Usually means like take the surgery right away and get it out, right? I think,
when I talk to them and tell them, it's really hard for patients when they go to cancer carcinoma and all that we need is our only curative agent is surgery. First, the patient has to get surgery as soon as possible. So explain why doing something true. So that's one good thing to do.
Or a comment or two. I mean, how do surgeons feel about doing a major hepatectomy after Y90 or after external beam radiation? And let me add that we did a recent NISQIP analysis looking at the short-term outcomes of hepatectomy for colorectal liver mets and HCC and for ICC. And surprisingly, the results were worse with ICC.
So, I'll comment on that since we're a huge center and literally Y90, everybody who walks in. We actually, Talia Baker and the group wrote a paper on this topic because there's really not much in surgery and Y90, especially for transplantation as well, where we literally have 3 sessions of Y90 and we transplant these patients. It's limited. When the Y90 is done, sometimes you have to, for example, resect the diaphragm at the same time just to positive margins or the hilum can be distorted or so, but it's not really avoided any case because of Y90. It's certainly better than SPLT, I feel. But it's definitely doable. We just have to get used to it, which we have. But I would encourage surgeons just to do it because you have we achieve excellent results with the Y90 and hypertrophy remnants. So we wrote a consensus paper on that a couple of years ago.
Just a quick question for insurance. If you have a localized disease, do you have any issues with insurance for immunotherapy if it's localized? Trying to get it from a side tumor.
It might be an issue. Sorry. It might be an issue. So insurance, you can advocate, and if you present the data, the most of the time they accept. Now the emergence seems to be less of an issue, so I can use that treatment in the setting. Justice Justice of Rax, and I'm using the neoadjuvant setting, which clear masses.
So you're this patient later on the side, when you just Durga or when you look monotherapy Pembra?
I wouldn't use monotherapy personally.
Right.
And once I had just a single agent pembrolizumab has very high response rate, including complete response with very limited toxicity. I had patient that almost had complete response, so I would just put the chemotherapy in this patient.
And if this patient were MSS, what would your, for the large lesion, it would be?
So if it's MSS, so there are 2 answers here. The academic answer was on this log 1819 will be Genesis normal, but the reality is that Genesis adapting. As you know, it's just now seeing how response rate in this versus Genesis was not significant. So response rate is slightly higher. And that triple, when you want to convert someone to receptor, success in my personal experience. So if someone is young with function, still need to go.
So this patient for the genetic consultation is by today. Does have Lynch syndrome, and so the Lynch syndrome was responsible for colon cancer and then the uterine prophylactic operation as well. So she didn't get embolizumab. She went 7 cycles and it was restaged. Stage.
Interesting, yeah.
As you can see, a significant response. One question we don't know, which we'll address in the questions, is the duration. But so here we are. So the patient's doing well, they're feeling well, they're on single agent Bosamab.
Operate. And then you don't even need any R190 in this case. I mean, it's you have good remnant and excellent response.
To Cleveland Cancer World, we've seen complete response, complete after response. Just the continuing therapy.
The procedure will still show viable disease when we take it out, particularly even with Y90, when we get complete like imaging response, we still have viable disease. So I would personally still operate, just because of that risk.
Still a lot of.
Listen, no, coming from a patient who's had number two. So, yeah, I mean, I feel like cases. So in this situation, surgery seems much easier than, at the beginning, and we take advantage of that. This surgery, much the lowest other two types is to do immunotherapy to up to 1 year to complete the 1 year of treatment and then going into monitoring and surveillance. ctDNA in the adjuvant setting as well. Maybe that answers all the questions.
So, immunotherapy for rectal cancers we've seen in the watching later, even with the TNT approach. I think the difference here is that there's a complete clinical response. Radiographically, everything's gone, clinically, everything's gone, endoscopically, everything's gone. In this case, it's very hard to do watching rate when you still have radiographic presence of disease, and it's very anxiety provoking for patients and physicians. I had them few liver resections in colorectal liver mets who were MSI who got immunotherapy, still had disease on the scan, and admittedly took them out and there was no viable tumor in any of the three that I've done. But still, when there's radiographic disease there, particularly in cholangio, you said there's no data here. I 100% agree that resection needs to be part of this. Whether you do a couple more immuno versus now, then do the immuno on the back, and I'll operate now too as well. But
Yeah, we had this discussion. There was a question of should we get a PET scan to see if there's activity, but if the PET scan doesn't light up. I'm just curious to hear from people, Dr. Protomas, does that approach make sense? No PET activity, no complete response.
I still so we're just going to proceed with surgery and William's good. What if we don't do surgery and we lose that window? So I would rely on the PET scan to rule out neurosurgery.
Got it.
can I have a comment? The one thing about PET as well, it doesn't have the sensitivity detection of cellular persistence of disease, right? So there's a threshold of detection. And so that's why I get nervous about PETs there, because you just can't comment on that. And even if you take this out, and let's say you have 10% viable, but let's say it was like no viable tissue, there's still potentially selection bias and errors because they're not looking at they're doing, bread slicing and they're looking at samples. So you just never know whether there was a couple viable cells there. Now, whether they would be clinically significant later, I don't know, but that's my only comment with PET. The threshold of detection needs to be considered.
So we're at a surgical surgeon, so of course we went to the operating room.
Yeah, so actually I have a question. If this patient were not a surgical candidate and you had complete radiographic response, would you add local regional therapy? Would you just survey? What would you do?
Based on this particular response, we would not, unless you're looking to get on hypertrophy of the abdomen. This patient is constantly surgical.
Not a surgical. Okay.
Yes.
Response.
Yeah.
Would you survey?
The license patient and then.
As you can
I
see,
will, yeah, I will do that also close surveillance, right? We should-
Sorry, because you're missing your window too. I mean, it's just a very controversial thing. Yeah. We add, local regional, to be honest.
Everyone's looking for surgery, so we're going to take a rapid one, like a protective oath and you can see where there was a residual. You can have some of the mass, but you can give the representative photograph, not go a pathologist, but you can look at all the immune cell infiltrates that are there. So as they have taught me, lots of lymphocytes in there that were actually attacking the tumor. And they had trouble actually finding the size of the tumor. They kind of guesstimated 10% viable. So it wasn't a complete response, but they couldn't even give me a size of how much tumor was left. You can see the buttons were only given, there were 0 out of 12 in the lymph nodes, so it ended up being YP, T1 and 0. Of course, you knew this question was coming. So now what do we do in the adjuvant setting? Immunotherapy, do we go with capecitabine? Continue systemic gemcis, or start systemic gemcis, or just observe? Is there another option?
I would say do what was working and continue Pembro.
We're going to have trouble with approvals for that.
I think that if you were able to get in the neoadjuvant setting, you will be probably able to continue in the adjuvant as well. And that will be also my preference, as work in the neoadjuvant setting, data are clear that works also in the adjuvant setting, and as I mentioned before, up to 1 year. For the other option, if there was not an MSI high phenotype, Xeloda would have been actually even in a very early stage, a PT1, at least something to consider that are striking, but I will discuss with that. I think that as of today, gemcitabine cisplatin in the adjuvant setting has not point out to be better than Xeloda, so that will not be my choice. That's specifically from the MSI studies and melanoma studies as well.
Like months and then 6 months and it's 3 months sometimes and we don't know exactly what that is.
This is especially true in the study setting. I'll say up to 2 years, but honestly.
Yeah, and the question is, once you rev the immune system up, how long? I mean, she's 6 years no treatment.
Exactly.
6 months.
It's a big question. So how long are you gonna do it after for any solid tumor? And I think in this case, right, you got to beg for your buck beforehand. And I think we're really learning that neoadjuvant therapy, when there's a large tumor burden, is a lot more effective. So this might be a case where you've had a great response, where you have that tumor. You can create a really good, highly sensitive ctDNA assay for this patient. I guess they don't need any further data. And I think that data, if we start to see this trend in solid tumors like we are in colorectal, will really inform these decisions. Because although Pembro's pretty well tolerated, it's not perfect, and people will have issues, and they gotta have a port, and they gotta keep coming back for this sort of stuff. So I think that's where there may be a real powerful impact of how to really personalize adjuvant therapy.
Last question, because I'm a little bit out of time. Any concerns go back to the treatment while they're on Rozanab? Any concern with local or regional therapy?
No.
No, I think this is kind of the beauty of checkpoint inhibitor. They are very well tolerated and used very often in this disease in order to see some to addition, and I have not seen any increase in toxicity at all. So they can really receive the immunotherapy on the same day before the original therapy. So that's an advantage.
a lot of speculation from scientific and hypotheses. But I'm sure if we have strong data to support that yet, especially in cholangiocarcinoma.
I was just going to see if Dr. Portolans had been willing to comment on abscopal effects.
Yeah, so the two things, right? So if like to measure that abscopal impact, and he said there's a lot of trials around now, when the potential of the that knowledge us so there's a scope there to explore. Who are seeing more patients getting Gemcis Durva, and perhaps they're not resection candidates, but transplant candidates. And concern from a transplant surgeon perspective, of patients getting pre-treatment, pre-transplant or pre-operative immunotherapy. So far the only data we have is on really on HCC, and majority is coming from Sinai, and these are maybe cases that have been reported. The incidence of rejection is extremely low. That have been reported. That's again, it hasn't been. It's not quite clear if it's related to the immunotherapy or not. I mean, this needs to be investigated. We have done 24 cases now, a few on Pembro as well, and we have had really, a major rejection. So I think, and hopefully the Pembro as well in transplantation, and I have more studies, and there's some clinical trials on HCC that we'll have the results shortly. So we'll see what they show. And yes. I think what we're learning is that timing is extremely important. So immunotherapy, adjuvantly with the transplant is so as long as you give some sort of washout of the last immunotherapy goes, and then the time of transplant with at least for 8 weeks beyond that's when the blood out. So, but evidence of transplant, months is recommended. We have had more rougher periods because just we didn't know at that time, but now it's close to 3 months. I think more important, besides the rougher period, an observation period as well to make sure that immunotherapy and systemic, we don't have those direct cases because patients just had terrible explant pathology and recurrence post-transplant because there's really not good options post-transplant in terms of immunotherapy. So 3 months will be my safe answer.
Just over time. So thank you very much to the panel. Thank you to the Cholangiocarcinoma Foundation for the continued support of this session. And as Melinda mentioned, hopefully see you in Salt Lake City in April. Thank you. Well, we get together. I think
Close enough. Thank you. Just look at you. I got an angels. Not.